Next speaker, with the permission of Dr. Bhaskar, Dr. Samresh, and Dr. Diksha, if they permit, Dr. Kudlu has to go to this other session, so we would like to speak first. So if it's okay, then he'll be presenting on post-classic refractive error. As such, also he's the chairman of this session. So,
Thank you, Rajesh bhai. Thank you, Ajay, for the kind introduction. I excuse myself. Can you switch up my? Yeah. Actually, I'll be talking about something complications of advanced surface ablation and management. Um, no financial disclosure for this talk. So, what are the common complications it can come across? One might be having a delayed epithelial healing, post PRK haze. You may have a decentered ablation with irregular astigmatism, and of course, one of the dreaded complication is infectious keratitis. So coming to the why there is a delayed healing, because sometimes what happens with the uneven removal of the epithelium, and sometimes even with the larger zone. And the other causes like over usage of steroids and non-steroidal anti-inflammatory drug. Patient might be already having a very severe dry eye also. And even it can happen in patient with immunocompromised patients, and also improper irrigation following alcohol and also MMC application. So coming to the management, it's very simple. If you are putting them on a non-steroid anti-inflammatory drug, stop there, then quickly you taper the steroid. Even if it is not responding, sometimes autologous serum is not a bad option. Put plenty of lubricating, that means hourly or half an hourly. And very important during the pre-operative step, that avoid excess use of mitomycin C during the procedure, and you need to, if you use also, you need to have a thorough irrigation. So coming to the decentered ablation zone, normally this center of ablation does not correspond to the optical axis. So glare, halos, even ghost images and blur vision can happen. So why this decentered ablation happened? Because of the one reason, poor patient fixation, poor patient instruction. Very important to note about the large angle kappa. It can even sometimes happen in a patient with over anxiety and even with over sedation. Sometimes when you are doing with the Alzheimer, you may lose the eye tracking. That might be the major cause. So coming to the if you are having a decentered ablation, when you're thinking about diagnose, always patient will have a reduced best corrected visual acuity. Also, you can see in the tangential map, we can see the decentered zone of ablation. Of course, there will be definitely increased higher order aberration on aberrometry, especially you will have a more coma. And also, if you do autorefractometer, then whatever the cylinder it gives, which might not be correlating with the manifest cylinder. So coming to the treatment, if the decentration is around less than 1 mm, patient is not too complaining, then best to observe. If the decentration is more, like suppose more than 1 mm, then if the patient is having significant visual symptoms, then proceed for the treatment. This is a small chart I am just putting you. Even people tried with the contact lens trial. If you see that there is improvement in the symptoms, then you can continue with that. But if the patient is not willing, then you should plan for either a topo-guided or wavefront guided treatment. So then always when you're doing, always you should look for the lenticular status, especially those who are having eye trace, no financial disclosure. Look for the dysfunctional lens index, and also look for the nuclear scan also, and also you should look for the internal abrasions. So coming to if you are having already decentered ablation zone, if the patient is having poor DLI, then if you have got a higher internal abrasion, then always you should never touch them with the excimer laser. Rather, you should go with the lens-based approach. If you think that patient is having a good dysfunction lens index with normal higher order aberration, then I think binocular vision, even orthoptic assessment you have to do. Because Dr. Rohit Shetty is sitting here, one of the genius in refractive surgery. He always used to tell me that always for all these refractive patients, binocular testing is very important, and even with the orthoptic assessment is the very, very important test to do. So this is about the treatment. So most of the study shows that the topo-guided treatment will be much, much better than the wavefront guided treatment. So this is about the topo-guided ablation for the decentered treatment. See, you can see that a lot of change, like from the pre-treatment to the post, you can see which is well centered. which is respect to the visual axis. The other complication you can see is PRK haze. Normally, there is what happens, there is a loss of corneal clarity, which is early or late onset, which can happen around in 0.5 to 4% of the patient at 6 months. The reason for the patient will have a refractive regression also, reduced visual acuity, and it may cause irregular astigmatism. These are the pathophysiology of the PRK haze. So there will be a fibroblast, and all depending upon how the corneal remodeling happens. So what are the risk factors for post-PRK haze? Especially high level of refractive error, more than 6 diopters, depth of ablation more than 90 micron. It can happen in patients with high astigmatism, and the type of epithelial removal and UV exposure. So what are the precautions? I think careful assessment is very important. Intraoperative use of MMC in case of when you're doing PRK. Avoid excess UV exposure post-procedure, and medical management, especially with corticosteroid and cyclosporine. So of course, corticosteroid is the way to start with, but it may cause a delayed wound healing. There is a chance of increased risk of infection too, and even if you put for a longer period, the chances of posterior subcapsular cataract is also quite high. So cyclosporine nowadays, I think it prevents the T cell from releasing cytokines, which does not inhibit the corneal wound healing, no serious drug-related event, and which is safer for prolonged use. So as the cyclosporine, which acts on the early phase of the pathophysiology, what I feel that it should be started very early, in fact, even in the preoperative stages also. So post-PRK treatment haze, short tapering of the steroid 2 to 4 weeks, then continually start the cyclosporine, continue for up to 6 months. If there is no resolution, then you can plan for mechanical scraping with MMC, or you can do TPK with MMC. So this is the last complication, that is infective keratitis because of overuse of topical non-steroid anti-inflammatory drug. So normally early onset versus late onset. Early onset normally might be staphylococcus, or late onset might be acanthamoeba or atypical microbacteria. So the treatment short trial of topical steroid, improves seen, continue the taper steroid, no improvement, then start antimicrobial therapy, then send for culture. So under correction, over correction can happen. Why under correction? Because of improper refraction, wrong refraction, and improper laser setting. Management, if the patient is not complaining, epithelial remodeling sometimes may correct. If significant, plan for treatment, wavefront guided treatment. The other complication can happen like regression, ectasia, and dry eye symptoms. So you need to tackle them preoperatively very well. So take home message, nowadays most of us been doing advanced surface ablation in the recent years. Because of high expectation of the patient undergoing this procedure, it is important to recognize and address potential complications. With appropriate patient selection, meticulous surgical technique, and diligent postoperative care, almost any complication of advanced surface ablation can be managed with utmost accuracy, restoring the useful visual acuity. Thank you, one and all.
Thank you, Dr. Kudlu, for a wonderful talk. I think surface ablations are definitely a very good technique still. So, any questions from the audience? Yeah, please.
Especially when we do the very simple test of Sherman's, if I think that the patient is already having a borderline dry eyes, then I start them preoperative only, just a week or couple of weeks before only, then I continue them for a period of 2 months, sir. Yeah, specify. If the Sherman's is good and if all dry eye workup, then post-operatively for every patient I start cyclosporine.
Thank you. So we'll move to the next talk.
Sir? I use, sir. I use minimum of 3 to 6 months cyclosporine.
How long does it take the PRK haze to disappear, sir?
Uh,
How long does it take for the PRK haze?
PRK haze, again depending upon the patients, normally it resolves by around 3 months. If you put them aggressive steroids, it can disappear quickly also, but you need to know about the complications of steroids use also. But if you, I think, aggressively put them on prednisolone, like start with 4 times for a week, then tapering and all, even I have seen patients within 1 month they regress. But if you put them on fluorometholone or loteprenolol, then I think it will take up to 3 to 6 months.
I've I've seen a patient, he has come with a haze after 6 months also, sir.
Yeah, then again you have to start them on steroid, taper them and wait.